Hi, welcome to the Bronchial Asthma in Children. I am Dr. Bibiano Reyes Jr., a pediatric pulmonologist. It is the objective of our lecture for today is to correctly diagnose a child with bronchial asthma and properly manage a child with bronchial asthma. Asthma is defined as a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. This slide shows a graphic representation of a bronchial hyperresponsiveness. There is excessive contraction of airway smooth muscle, uncoupling of the airway contraction as a result of inflammatory changes in the airway wall, leading to excessive narrowing of the airways. Thickening of the airway wall by edema and structural changes amplifies airway narrowing due to contraction of airway smooth muscle for geometric reasons. Sensory nerves may be sensitized by inflammation leading to exaggerated bronchoconstriction in response to sensory stimuli. The gold standard for diagnosis of asthma is spirometry, which measures the forced expiratory volume in 1 second, or FEV1, forced vital capacity, FVC, and the ratio of FEV1 and FVC. For children 5 years old and below who cannot perform spirometry, we can do a therapeutic trial by giving steroids and bronchodilator for 5 days. If there is improvement in 5 days, then we can diagnose a child with bronchial asthma. A pre-expiratory flow mode of diagnosis in children is not recommended because it is effort dependent. The most common trigger for asthma is still viral upper respiratory tract infection. Other triggers can be due to exercise, exposure to dust, smoke, pollen, molds, strong odors, drugs. Food is the least common. This means that it is not necessary to prescribe hypoallergenic diet. We must also consider wrong traditional Filipino health practices which might worsen asthma. It is our duty to remind them that it is wrong and must be stopped, like mentholated oils applied every day, which might trigger bronchospasm and lipoid pneumonia. Hilot belief, which we all know at this point that Hilot practices has no evidence and may further aggravate asthma. We must correct poor hygiene practices, not allowing their children to take a bath, especially when sick and at night. In infancy and early childhood, viral infections are the most common trigger factor of asthma, while exercise irritants, indoor irritants, and pollens are the frequent triggering factors in late childhood and adulthood. Food may be a trigger factor in infancy. Emotions may be a trigger factor in asthma exacerbation. It is important to differentiate different types of exacerbation in children because the choice of management will depend on the type of exacerbation. The most important parameters for exacerbation in children that can be used right away to diagnose an asthmatic attack is through the parameter of breathlessness and tox-in. We say that the child in mild exacerbation has mild exacerbation if the child can lie down or can talk in sentences. While in moderate exacerbation, an infant will have shorter cries and prefers sitting, while a child would prefer sitting, and usually these children will talk in phrases. We say that it is severe when an infant stops feeding, or a child would prefer at rest and hunch forward. And when they talk, they only say words. This is another set of table differentiating types of exacerbation. And another table for different types of exacerbation. There are two types of management in asthma, the relievers and the controllers. The relievers are taken as needed for exacerbation, like the short-acting beta-2 agonist and the anticholinergic. The controllers are taken daily to prevent future attacks. Example are corticosteroids, inhaled or systemic, leukotriene modifiers, long-acting beta-2 agonist, sustained-release theophylline. What will we do if we encounter a child in exacerbation? For children 6 years to adolescent in mild to moderate exacerbation, first we give short-acting beta-2 agonist at least 4 to 10 puff using a meter dose inhaler plus spacer every 20 minutes for 1 hour, or via nebulizer 1 neb continuously for 1 hour, or every 20 minutes for 1 hour. We can start oral corticosteroids and maintain O2 saturation to between 94 to 98%. Then we reassess patient for 1 hour. For 5 years old and below, in mild to moderate exacerbation, you can give SABA 2 puff by meter dose inhaler plus spacer, or nebulize every 20 minutes for 1 hour. Start OCS or oral corticosteroids and maintain saturation between 94 to 98%. Again, observe patient for 1 to 2 hours. For 6 years and to adolescent, if the mild to moderate exacerbation is not improving, the patient is on severe exacerbation, or when you assess patient in life-threatening situation, this is an urgent care and must be transferred to acute care facility right away. You change your nebulization to SABA and ipratropium bromide. You give oxygen, start on systemic corticosteroids, consider giving IV magnesium, consider high-dose inhaled corticosteroids, and refer to specialist. For 5 years old and below, with worsening mild to moderate condition and severe exacerbation and life-threatening features, the same thing, this is an urgent care and do the same procedure. The success in treatment on asthma relies on the proper use and type of inhalation device. For meter dose inhalers, plus spacer is needed for 6 years old and above. First, you remove the cup and hold the inhaler upright. You shake the inhaler, tilt head slightly and breathe out slowly. Position the inhaler in your mouth. Press down on the inhaler to release the medication as you breathe in slowly. Breathe in slowly for 3 to 5 seconds. You hold your breath for 10 seconds to allow medicine to reach deeply in your lungs. Then exhale. For less than 6 years old, it is important to use, when using a meter dose inhaler, to use baby inhalers. This, make sure that it has a mask, a face mask connected. Instead of holding breath for 10 seconds, you count 10 breaths. Then you may do the same procedure again But first you have to pause for 30 seconds, then repeat if needed another puff, doing the earlier procedure. On assessment for discharge, make sure the patient improved, not needing any more short-acting beta 2 agonist. The O2 saturation is more than 94%. If the patient can do peak flow, make sure it has 60 to 80% predicted or best. And make sure you have resources at home like the nebulizers. Advise patient to continue relievers as needed and start or step up the medications by giving inhaled corticosteroids. You may also advise the patient to continue oral corticosteroids for 3 to 5 days and advise follow-up to their pediatrician within 2 to 7 days. Okay. In summary, in an acute asthmatic attack, it is very important to take a brief and focused history and do a quick physical exam. Assess the asthma attack severity right away, whether mild, moderate, or severe, to give you a guide on how to institute initial management like oxygen, nebulization, and supportive measures. That's all, and I hope you learned on our lecture on bronchial asthma. Thank you very much.